Good morning, and thank you for coming. I'm Dr. Robin Cohen from the Keck USC School of Medicine in Los Angeles. We're very pleased to hold the press conference for the 2016 Society of Thoracic Surgeons annual meeting. We have 3 papers that were chosen from a huge number of patients or papers that we hope have a lot of clinical relevance. The first one is entitled "Race is Associated with Reduced Overall Survival Following Esophagectomy for Esophageal Cancer Only Among Patients from Lower Socioeconomic Backgrounds." It'll be presented by Dr. Loretta Erhunmwunsee, formerly of Duke University, now of City of Hope Medical Center in Duarte, California.
Thank you for the opportunity to present our work. It has been well established in the literature that Black patients with esophageal cancer have worse survival than white patients. The reason for this disparity, though, is unclear. One potential cause of the higher death rates in Black esophageal cancer patients is the fact that there are major socioeconomic differences between races. For instance, the median financial net worth of Caucasians is 10 times that of African Americans. Studies have shown that differences like this can and do result in healthcare inequities. We wanted to determine the impact that socioeconomic status has on racial differences and outcomes in those who had their esophageal cancer resected by a surgery we call esophagectomy. We predicted that esophagectomy patients with low socioeconomic status will have worse overall survival regardless of race. We used the National Cancer Database, also known as the NCDB, to examine STS, or socioeconomic status, and race, and the impact of these 2 factors on survival in esophagectomy patients. In short, the NCDB represents 70% of newly diagnosed cancer cases. This diagram shows that we used the database to find patients with esophageal cancer that had not spread to other organs and who were diagnosed between 2003 to 2011. We excluded patients who were either not Black or white, who were not between the ages of 18 and 85, and who had incomplete data. We ended up with close to 17,000 stage 1 through 3 esophageal cancer patients, or 6,000 of whom underwent esophagectomy as part of their treatment regimen. Only 5% of our esophagectomy cohort was Black. When we compared Black patients to white patients, we found some differences. One, Black patients tended to be younger. Black patients had a higher percentage of females in their group, and Black patients were less likely to have private insurance. We saw no differences between their level of overall health, which is depicted here by the Charleston Comorbidity Index, and we saw no difference between whether they got therapy before their surgery. We also didn't see a difference between stage amongst the races either. But we did see that Black patients tended to have a longer length of stay after their surgery. And Black patients were more likely to have a subtype of esophageal cancer called squamous cell cancer, while white patients were more likely to have another subtype, which is called adenocarcinoma. Black patients were also more likely to have their tumors be higher in their chest. So we looked at socioeconomic status in our study and defined that by using the average income of the households in the area where the patient lived at the time of their diagnosis. These household incomes were then grouped into 4 categories, or quartiles, that were divided equally amongst the income regions throughout the United States. The first quartile corresponds to the lowest socioeconomic status and includes the poorest patients, while the 4th quartile corresponds to the highest socioeconomic status and includes the most affluent patients. When we look amongst the quartiles, we see differences. In the poorest quartile, 14% of the patients were Black. Each increasing quartile has a corresponding decrease in the percentage of Black patients, and we see that in the 4th quartile, only 1.6% of the patients are Black. We also found that in the poorest quartile, again, the one on the far left, the patients were less likely to have private insurance, and the patients had a longer time from diagnosis to surgery. Also importantly, between the income groups, there was no difference in stage, and there was no difference in how sick the patients were overall. So we're going to look at survival curves, and for those who aren't familiar, we read them by looking at the vertical and horizontal axes. The vertical tells us the percentage of patients who have survived, and the horizontal tells us how long they have survived. So whichever curve is closest to the top of the page corresponds to the group with a higher survival. So when we focus on survival, we found consistent with the rest of the literature that Black patients who are depicted in blue had worse survival than white patients who are depicted in red. We also found that when you compared all of the income groups, there was an increase in survival with each increasing income quartile. So the poorest patients, again in blue, had the worst survival, while the wealthiest patients, who are depicted in brown, had the best survival and actually lived 24 months longer than the poorest patients. When we focus just on the poorest patients, namely those in the bottom two quartiles, or quartiles 1 and 2, we see that Black patients, again in blue, had worse survival than white patients. Whereas when we focus on the wealthiest patients, or those in quartiles 3 and 4, we see no difference between Black and white patients. We did further analysis to see which of the above factors that are listed here had an important influence on survival. Once we calculated for these factors, we noted that in the lower income quartile, race was important, and therefore Black race was associated with worse survival. But race, very importantly, was not important in the high income quartile. Not surprisingly, older age and more advanced stage was associated with worse survival in both the lower and higher income groups. And surgery in a non-academic facility was associated with worse survival in high income groups as well. So many prior studies have revealed that Black patients have worse survival after esophagectomy. We have shown that only Black patients with low socioeconomic status do worse, and that Black and white patients in higher socioeconomic groups have no significant difference in mortality, while poor Black patients have the worst survival of all groups. Certainly, as with any study, there were limitations. One of our primary limitations was that there was a small number of Black patients who underwent surgical resection and a small number who were in the upper income quartiles. But we believe that these small numbers are actually part of the overarching health inequity problem, and that this finding actually gives credence to our work. So we conclude that racial disparities seen in esophagectomy survival are directly impacted by socioeconomic status. Black patients do not do worse across the spectrum of socioeconomic status, and that among the higher socioeconomic status patients, Black race is not associated with worse survival. However, among lower socioeconomic status patients, Black patients do worse. Thank you.
Hi, Ed Sussman with Oncology Times. You care to speculate why the lower income patients do worse?
Absolutely. Well, I think unfortunately, the problem is multifactorial, and I think there's not just one answer, but the overarching answer is that, poor patients have decreased access to care, and they have decreased access to good, consistent care. I think, unfortunately, those who are in poor groups also have other things that impact their care, meaning that we've seen that they have a higher degree of smoking. They live in worse neighborhoods many times. Their jobs may be more blue collar, and so they're more at risk for injury. And many times poor patients are exposed to violence at a different rate. I think specifically with our study, that's our major question that we want to answer, and we're hoping to do further studies to really look into why this is the problem.
If I got your data right, black poor people do worse than white poor people.
That's right.
Why is that, do you think?
Absolutely. That jumped out at us as well. And I really believe that the reason black poor patients do worse than white poor patients is because black poor patients are poor. I think fundamentally that is the issue. Unfortunately, with this database, we can't look at that directly because you would need to be able to have a continuous income variable or be able to look at each patient's income. But I bet if we could look at that, we would see that black poor patients are actually poorer than white poor patients.
Knowing what you do with this study, what are some of the steps that you can take to help change the numbers?
Absolutely, and that was the whole point of the study, was to try to make an impact. And I think one of the first things we need to do is make it clear that this is the problem. And I think sort of getting the data and the information out there, because we can then understand that low socioeconomic status is actually a risk factor for doing poorly. And so when we have these patients, we can, maybe do extra measures to make sure that they stay engaged, that we find them early, and that we help them through the process. I mean, there are many different potential things we can do. Some centers have tried to employ navigators who, when they realize patients are at particular risk, are able to help them through the process, and I think that's something that we could try to make more available. And also, I think potentially, one issue to your question earlier that poor patients see is that many times the hospitals that they may go to may not have the best outcomes, and so if you can maybe partner hospitals with better outcomes with those hospitals that are in the community where they see these patients and maybe bring up the care that those patients get, that's also possible.